Okay, well let's record this mood lecture. I actually recorded it once before. I thought I recorded it, but it was not on. Um, anyway, here we are with mood. I believe it's chapter 15 in Vedabek. The editions have changed, but I believe the chapters have stayed the same. Let me just make sure we are recording. We are. Okay, so mood disorders are also known as affective disorders. All people have normal variations in mood. This is what makes people interesting and different. If everybody's mood was the same, the world would be very boring. When variations in mood become so severe that they affect functioning, do we consider them an illness? And this is really the definition of all mental disorders. They have to affect functioning to some degree. Okay? Moods can range from full-blown depression, suicidal depression, to full-blown mania. And mania is a sense of high energy, grandiosity, meaning self-importance. You think you're greater than you really are. Um, don't need sleep. You're hyper. It is very, very similar, if not identical, to the cocaine high. And if we go back and think about those neurotransmitters in the cocaine high, cocaine causes a release of dopamine, adrenaline, and serotonin, and then blocks the reuptake of those neurotransmitters. So those neurotransmitters sit in the synaptic space and hit their receptors. Mania is also an excessive amount of those neurotransmitters. So the biology behind cocaine or stimulant abuse and mania is very, very similar. Okay. Well, one of the main neurotransmitter here is serotonin, and a little sidebar here. L-tryptophan is the precursor to serotonin. Serotonin also has calming properties to it, and that's probably why you have food coma on Thanksgiving. Everybody eats a bunch of turkey and lays on the floor and falls asleep because turkey has a lot of L-tryptophan in it. Some people might say, well, why can't you give someone who's depressed just L-tryptophan? Because the enzyme that converts the L-tryptophan serotonin does not do it. If you just give someone more L-tryptophan, it doesn't mean that that chemical reaction happens. Okay. All right. Mood is an emotional state that affects the way one views the self and world. When one is in a good mood, the world is a beautiful place. When one is in a bad mood, the world appears ugly. Now, the world hasn't changed. What's changed is that person's view of the world. The world from day to day pretty much stays the same, and for that matter, month to month and maybe year to year. Affect is how one expresses their mood. Three descriptive terms here would be constricted, blunted, or flat. Constricted means the person doesn't show a lot of joy or a lot of sorrow. The range is constricted, narrowed. Blunted would be you ask someone how's they're doing, and they respond, I'm okay. Kind of blunted. Flat would be, how are you doing? I'm okay. Even less, no minimal emotions with flat affect. Depression is very low mood for a specified period of time. We will look at the diagnoses as per the DSM, and those time frames vary depending upon the diagnosis. And again, as said before, probably low due to low levels of serotonin, and depending upon the types of depression, low levels of adrenaline or norepinephrine and dopamine. Mania is a pathologically elevated mood resulting in poor decision making and impulse control, resulting in promiscuity, possible excessive spending, buying things, credit card spending, and many times in type 1 bipolar disorder, which we'll talk about in a few minutes, extreme grandiosity. And again, this is probably due to high levels of serotonin, adrenaline, and I want to add norepinephrine and dopamine. Well, hypomania is less than full-blown mania. The person is very energetic, might not need a lot of sleep. They can study very, very rigorously, stay very focused on a task. It does not go into the psychosis that full-blown mania can go into. Another symptom of a mood disorder is anhedonia. Again, hedonist loves pleasure. A without, so these people do not feel pleasure. Dysthymia is actually a diagnosis that person has a low-grade smoldering depression. We'll talk about that in a couple of slides. Dysphoria is actually an adjective and it means poor mood. Well, but depression is more than a poor mood. Severely depressed patients can have other physical symptoms, and one group of symptoms here is called neurovegetative signs. Literally, the body, the autonomic nervous system slows down, okay, resulting in constipation, a lack of energy, decreased sex drive, sleep disturbances. So again, depression is more than just a poor mood. Also, another symptom here, psychomotor retardation, results in slowed physical and emotional reactions. They literally think slower, they respond slower. Sometimes that's called a latency of speech. You ask them a question, and there's a couple second gap before their response, or maybe more than a couple of seconds before their response. Latent speech. A rumination means they might think the same thought over and over and over and over. Um, Rumination, that term actually comes from a cow. A cow has like 7 stomachs, and they upchuck their cud back to their mouth and they chew it again. That chewing again is rumination, okay? And I believe Freud coined this term where people just keep thinking over and mulling over the same thought. Another symptom in depression, particularly, is somatization. Soma means a body, I believe in Greek. These people sometimes feel that there's something wrong with them. They have another illness. In fact, we worked with a gentleman, I worked with a gentleman who thought that he had prostate cancer. They did tests on him. He did not have it. I went to his room and it said, they determined you don't have prostate cancer. And he says, yes, I do. Yes, I do. And I said, there was no way we were going to convince him that he didn't have prostate cancer. He had a psychotic depression. As it turned out, very sadly, he was retiring from work and moving to Arizona. And those losses led to a depression. Because think of retirement, that's very stressful. Moving is very stressful. And though that level of stress, he couldn't take that the stress that it caused, the anxiety that it caused. So actually what he felt he had prostate cancer. And I asked him, what makes you think you have this? And he said that if his mother told him that when he was a young boy, that if he masturbated, he was going to get sick. And he said, I'm getting sick now because I was a bad boy. Very, very sad. And actually, in this case, I know where that comes from. I'm a Catholic. And I called up the priest, the local priest in the hospital, and he came and talked to the man and said that is not a sin, which is a very wonderful interpretation. Somatization is blaming a psychological symptom on something physical. In the case I just gave you, he blamed his feeling of feeling bad on prostate cancer, which he did not have. Oh. So general symptoms of depression, low self-esteem, and this is a hallmark part of depression. This almost defines depression. Low self-esteem. You also have fatigue, excessive guilt, anxiety and worry, pessimism, anhedonia, again, loss of pleasure in life activities. And something that I noted and a psychiatrist told me about, symptoms tend to be worse in the morning when people are depressed. It makes somewhat sense. If you were depressed and you had a full day in front of you, you would say, my God, how am I going to get by this day? How am I going to get by this day? This day is so long. And then maybe by 2 or 3 in the afternoon, you say to yourself, oh, I've made it through the day. I've made it through the day. Good. Oh, I feel a little better. So it kind of makes sense that if you don't have the energy for the day in front of you, that you're going to feel sad. Physiological sleep changes more or less. Usually it's more sleep. Changes in eating, decreased energy, decreased sex drive, constipation we spoke about, psychomotor retardation we had mentioned, physiological symptoms of depression. Cognitive symptoms here, again, slowed thinking, possible psychosis, okay, in a paranoid type, or severe somatization. Again, we spoke about this gentleman. He was convinced he had prostate cancer. We could not convince him otherwise. The only thing that helped him was we had to give him electroconvulsive therapy. They put him on Prozac and an antipsychotic, and over time his thoughts cleared. And again, that was related to his impending retirement and his move from around here to Arizona. Those are losses, major losses in people's lives, or major changes. Depressive symptoms in age. Let's look at this. Young children, they can demonstrate apathy, poor appetite, or failure to thrive. They know that young children, very young children, infants, if they are not held by their mother or someone who holds them warmly, they cannot develop normally. Failure to thrive, and they realize this through orphanages that did not have enough staff to really hold all the children there, and the children didn't suffer from a lack of human touch and warmth, and failure to thrive. Older children can get irritable, can have crying spells, enuresis, which is bedwetting, poor school performance. Again, we have to know someone's baseline, because if someone has always been somewhat poor at school, that's just the way they are. Or if they're always a little bit irritable, that could be their personality. The thing here is we look for a change from baseline. Okay. Adolescence, labile mood, frustration intolerance, argumentative, sexual promiscuity, hypersomnia means sleeping a lot, decreased socialization, resulting in few friends. Look at this. Typically in adolescence, their mood can be labile. They do tend to have frustration intolerance. Teenagers can be a little argumentative. They can be sexually promiscuous. They sleep a lot and late. The difference here is teenagers are highly social. Sorry about that ring. Um, they're giving up friends. So really, a teenager that's not social, there's probably something going on there. Okay, because the other symptoms can be just a normal teenage. Adult. Okay, we spoke about these symptoms. Again, I mentioned low self-esteem, hallmark, guilt, giving up friends that used to be quite friendly. Now they're kind of retreating and not going out. Psychomotor retardation, somatic complaints such as always feeling sick, nauseous, always feeling aches and pains, rumination, and again, a lack of pleasure. I've also heard that patients say, several patients I've worked with depression, say there's an emptiness, there's a hole around their stomach, in their body, they feel an emptiness. And once you treat that depression, that emptiness goes away. They will also sometimes feel they have cognitive deficits, that they're not thinking clearly. And you give them, they may have some slowed thinking, but their memory is basically intact. They don't feel that way, so they have perceived cognitive deficits. Affective disorders, as per the DSM. The DSM, once again, is the Diagnostic and Statistical Manual of Mental Disorders. And again, this is an evolving book. It changes, as I had mentioned in some other lectures. Prior to 1980, if you were gay, you were considered mentally ill. And then they realized, the people who write that book, that people that are gay are perfectly normal, healthy people. Okay? There's nothing wrong with them. So that really demonstrated a lack of neutrality prior to 1980, people who were creating the DSM. Okay. MDD, major depressive disorder. This is severe depression, usually lending itself or leading to possible suicide attempts. Dysthymic disorder. This is a low-grade smoldering depression. We'll talk more about that. SAD, seasonal affect disorder. Talk about that in a few minutes. EDD, premenstrual dysphoric disorder. Again, we'll get to that. There's also postpartum depression. And there's three types of bipolar disorders. Type 1 is the most severe. You have full-blown mania to the point of psychosis, where you might believe that you're Jesus Christ or President of the United States. And then you can go into a full depression. Type 2 is you tend to have hypomania. You have energy and you feel good about yourself, but you're probably not going into a psychotic mania. Okay? But again, with type 2, you can go into a full-blown depressive episode. Cyclothymic disorder. These people tend to be moody. Okay, their mood can change rather quickly. You can look at bipolar disorder as somewhat similar to diabetes. Diabetes type 1 is the most severe. Diabetes type 2 is less severe. Okay? Let's talk about major depressive disorder, also known as MDD. You must have extreme sadness for at least 2 weeks. So if you wake up one day and you feel sad, you don't want to go to school, you don't want to go to work, you just want to stay in bed and pull the covers over your head, and you do that for a day or maybe two or even three, it's not really considered major depressive disorder. This has to be around for at least 2 weeks. Okay, again, we spoke about loss of interest in previously pleasurable activities, insomnia, hypersomnia, fatigue, excessive unjustifiable guilt. I worked with a woman who came in with depression, and she would tell me her kids, she was a terrible mother, she was a terrible mother, she was a bad mother, and her kids were there every single night visiting her in the hospital. I said, but your children are here every night. They love you. They're here every night to talk to you. Oh no, that's just they're just doing that because they have to. They don't really love me. When people are depressed, they cannot feel pleasure. They cannot really feel love and warmth because those love, warmth, and pleasure are controlled by neurotransmitters, serotonin in particular, maybe some dopamine, maybe some norepinephrine. But when those neurotransmitters are just bottomed out, the person cannot feel pleasure. They could win the lottery of $10 million and they wouldn't feel the joy of it. Okay, because they can't. Without the neurotransmitters, you can't feel the joy. Let me just make sure we're still going. We are, okay. Uh, Sometimes a decreased ability to concentrate, extreme indecisiveness. They may walk in the room and say, oh, where should I sit? Should I sit over there or over there? Okay. Over time, they can get fixated on suicidal ideations. That's what SI stands for, or a fixation with death. Okay. So this has to be treated. This tends to get worse. Most mental disorders without some kind of treatment tend to get worse. Not all of them, but they tend to get worse. And that's related to the concept of kindling, which we'll talk about in a little while. Okay, bipolar disorders, also known as manic depression. I'd like to say here that I heard about half of the famous artists, musicians, artists, about half of them are bipolar. Okay? I mean, Jimi Hendrix wrote a song called Manic Depression. Okay, so he must have some knowledge of manic depression, right? Bipolar type 1, most severe form, severe mood swings. And generally, these mood swings um, could last several months. Okay, and then you feel manic for several months, and you go into a mania, then you go into a depression after that, and then you're there for a few months, then you go back into mania. Um, they actually say if you're cycling more than 4 times per year, that indicates that it's a little hard. You have very unstable bipolar disorder, harder to treat. Overall, bipolar disorder is one of the more difficult psychological illnesses to treat. One of the reasons being is the patients tend to like mania, so they stop taking their meds. And remember, mania is a stimulant, i.e., cocaine high. So they like that feeling, so they stop taking their meds. Let's see. Again, they can have psychotic grandiosity. And then talking to that story about the woman who said her children didn't love her, she got better from her depression. She was discharged. About 4 or so months later, she gets readmitted in a full-blown manic phase. I asked the doctor, I said, doctor, what happened here? He said, well, she was bipolar, but I didn't know it. There was no way for the doctor to know that she was on the bipolar continuum. He thought that she was unipolar, one pole, just depressive. Okay. So he put her on a mood stabilizer and on her mood elevator also. So the mood stabilizer, probably Depakote or lithium. We'll talk about that in a little while. But while she was in this manic phase, she sold her home and bought racehorses and a quad for her 6-year-old grandson. So she sold her home and just started spending money frivolously. Okay? We also had a patient who thought he was the best accountant in the world. He had a jacket on the back of his jacket said, "I am the best accountant in the world," with his phone number. Another patient who was the greatest disc jockey in the world. He called himself Mixmaster Mike, the greatest DJ in the world. So this is grandiosity. We are still recording. Good. A bipolar 2. This is a milder form. Okay, a milder form of bipolar disorder and tends to be hypomanic, in other words, below full-blown mania, but they still have the full-blown depression, still become suicidal. Probably no psychosis here. And the last type here, I joke around, this is the rest of us, because humans can have mood changes, right? Cyclothymic, mildest form of bipolar disorders. Mood swings range from mild elation to mild depression, and these people are usually seen as moody and unpredictable. People who are in a manic phase, when they get angry, they can get very, very angry. Okay, there was a time I worked in a hospital. We had to put a young man who was just admitted. He was tried to get out of the hospital by coming into the center unit where he thought the staircase to leave was. He did this many, many times. Finally, we had to put him in seclusion. And while we were doing that, he looked at me and yelled at me. And he said, "Your toupee looks terrible." And this hair is real, man. This hair is real. Okay. All right. Another case, a hospital I worked at. Patient was admitted for setting his parents' car on fire. First, he set the house on fire. With them in it, they fled to the car. He followed them and tried to set the car on fire. Another person I work with, a female patient here, the boyfriend broke up with her and she scratched and really trashed the boyfriend's car. People that are manic, they really can get rageful, and we have to be quite careful, okay? Well, I worked with a person who said he was just manic. I've never heard of this, but he said, I'm just manic. I don't have depression. Again, I've never heard of this. But anyway, he lived in 5 towns by Kennedy Airport. And in a manic episode, he walked from basically Kennedy Airport all the way to Nissaquag River Road in Smithtown, which is probably about 50 miles. It took him a week. He was looking for Jesus Christ. He told me his whole story. He was looking for Jesus Christ. Well, walking down River Road, he sees this house with a big front porch, and he said to himself, Jesus Christ is going to meet me on the front porch. So he walked on the front porch, sat down, and waited for Jesus Christ. Well, needless to say, Jesus Christ did not come, but the homeowner did come home, and she pulled up, rolled down her window, and said, "Can I help you?" He said, "I'm waiting for Jesus Christ." And she said, "Oh, okay." Of course, she called 911, brought him to the hospital. He did get treated. I actually worked with him, and he was a very good nurse's aide, although I had to treat him very gently and not make him angry because he could be quite edgy sometimes. Okay? Just a little sidebar story there. Let's look at some other DSM diagnoses for mood disorder. We had mentioned earlier, a few slides back, dysthymic disorder. This is a chronic low mood and other mild signs and symptoms of depression for at least 2 years. So really, this becomes part of the person's personality. These people view the world something like this: life sucks and then you die. That's not the way life is supposed to be. Because if there was no pleasure in life, the human race would have never made it this far. We as humans, or any animal for that matter, has to have enough pleasure to make life worth living. So depression, on that note, is pathological. If you're always sad and feel no pleasure, that's an illness. That's not the way it's supposed to be. But these people have gotten so used to that they just say, well, this is the reality of it. Life sucks and then you die. They're somewhat harder to treat than someone with major depressive disorder. Because someone with major depressive disorder, they feel terrible. They may want to hurt themselves. They will usually accept treatment. Where these people just say, hey, this is who I am and I don't like life. Some would say, okay, well, the treatment here could be insight therapy, have them lay on the couch and talk to a therapist, maybe cognitive behavioral therapy, how to change their cognitions, how to change their negative thought patterns. Okay. Another mood disorder is called SAD, stands for Seasonal Affective Disorder. This is a low mood in the winter, probably related to decreased sunlight. We know with less sunlight, we release less serotonin, and this is probably related to hibernation. We know that animals, bears, other animals, will hibernate and sleep through the winter. That makes biological sense because there's less food available. So they slow their metabolism down. They slow their metabolism to burn less calories. Well, we are animals, and many of us, I think most people feel a little less energetic in the winter than they do in the summer. It's a way to reserve calories, but the problem is our lifestyle continues on with artificial lights. Okay? Seasonal affective disorder. How can we treat that? Well, there is a treatment with bright lights that you can have bright lights come on, a full spectrum bulb, meaning it mimics the sunlight with the full spectrum of the rainbow. Okay. They come on at like 4:30 in the morning. Bright, so it kind of front loads your day with extra light, and you release cortisol and some adrenaline, and you wake up. Okay? We can also use medications. In fact, a medicine that is approved by the FDA for the treatment of this, I believe it's the only antidepressant that's approved by the FDA for this, not that other antidepressants couldn't be used, is Wellbutrin, bupropion. Okay? Bupropion blocks the reuptake, the presynaptic nerve, remember chapter 2, of dopamine and norepinephrine. Well, if we don't suck it up back into the nerve, it stays in the synaptic space. They hit the receptors on the postsynaptic nerve, and the person's in a better mood. But let me just say, a clinician can prescribe things, what's called off-label. Okay, Prozac has not been approved by the FDA to treat seasonal affective disorder, but it doesn't mean a clinician can't try it. And actually, that's the way you advance science, right? And medicine is by trying different techniques, right? So it can be treated with bright lights or medication. PDD, premenstrual dysphoric disorder. This is very, very severe PMS, rage and anger and severe irritability. Okay. Treatment is medication. Actually, you can use Prozac. Interesting case here. When Prozac patent ran out, Eli Lilly, the manufacturer of Prozac, applied for a patent to treat PDD, and that medicine was called Sarafem. Okay, so they rebranded it for PDD or PMS, but it was the same medicine. It's fluoxetine. Okay, and again, Zoloft would work. Paxil would probably work. Lexapro or Celexa would also work. Prozac got approved, did a study, and applied to the FDA to get approval for use in PDD. Also, postpartum depression, depression after childbirth, probably related to severe hormonal changes and sudden role change for the mother. In other words, when the woman's pregnant, everybody, oh, you're so beautiful. You have a beautiful pregnancy glow about you. God, you're so beautiful. And then the baby is born, and all the attention goes to the baby, and the mother feels left out. And also, hormones directly affect mood. In fact, I read an article that one of the potential causes of PMS or PDD is, I believe, it's either estrogen or progesterone. When that goes down, your GABA receptors become less sensitive to your GABA. Remember, GABA is sedating. If your receptors aren't reacting to your GABA, you become less calm, irritable, things like that. So there is a biological reason for PDD and PMS. Well, postpartum depression also. What do we want to do? Psychosocial support. Have someone, maybe the woman's mother, come and help her with the new baby. And we can also use medication also. Of course, we have to make sure that it's not going to affect the baby in breast milk if the mother is breastfeeding. So, etiology of mood disorders, though I've talked about it a little bit already, it certainly is a dysregulation of neurotransmitters, serotonin, adrenaline, norepinephrine, dopamine. Okay, It tends to have a familial component, okay, probably due to a genetic influence. If one identical twin has bipolar disorder, almost 100% chance that other twin will have some type of mood disorder. This means it's highly heritable. It's highly genetic. Okay? Highly genetic. Well, psychosocial theories of depression, psychoanalytic, psychodynamic, again, Freud, analytic and psychodynamic therapy focus on feelings. Whenever you think of Freud, think of feelings. He believed that depression was caused by unresolved childhood conflicts that result in anger turned inward. For example, a child is angry at his father but cannot show anger toward his father, so he turns that anger onto himself. Okay, I believe this. I think this makes sense. I don't believe in all Freudian stuff, but I think this makes sense. Cognitive behavioral. Again, the people here are Bex, Burns, and Ellis. There is a very famous book called Feeling Good. I urge all of you to read it because all of us have some negative thoughts, some irrational negative thoughts. And what this book teaches you is how to counteract those automatic negative thoughts. Well, he put those negative thoughts into certain categories and he called them cognitive distortions. And this is not to the level of psychosis. Overgeneralization, personalization, black and white thinking, catastrophizing, things like that. More right now. Black and white thinking. Something is either all good or all bad. You do poorly on a nursing exam and you say to yourself, I will fail every other nursing exam in the nursing program. I might as well just drop out. That certainly is black and white thinking. That certainly is jumping to conclusions. So what the cognitive therapist says, basically, the question here might be something like this. Do you have enough evidence to say just because you did poorly on one nursing exam that you're going to do poorly on every future nursing exam? And ultimately, the answer is no. Another one, arbitrary inference, jumping to negative conclusions without sufficient evidence. Specific abstraction, focusing on a single negative detail while ignoring positive details. Depressive people tend to focus on the negative. It's hard for them to see the positive. And the whole concept of cognitive therapy is to change that negative thought pattern, train the brain to look at things in a more positive way. Overgeneralization, forming conclusions based on limited past experience. One past experience was negative, then all similar experience will also be negative. Personalization, believing events are related to oneself. For example, you pass by a friend in the hallway and you say hello, and they don't say hello back to you. And you go to yourself, my God, I must have done something wrong. They don't like me. What did I do wrong? Oh my gosh. Oh God, I must have hurt their feelings sometime. When in reality, this person may have had a fight with their significant other, so they're just not in a good mood right now. It has nothing to do with you. Depressed people tend to personalize negative events. Again, cognitive therapy is to help them fight that automatic negative thought pattern. Let's talk about behavior. So many times cognitive behavioral therapy is put together into one, behavior therapy, and this would involve Pavlov and Skinner. Remember Pavlov's dog, when you rung the bell, the dog salivated? Okay. Patient learns depressive behavior from parents or through learned helplessness. You copy. Children are sponges. They are looking at their parents. And how does mommy and daddy react in certain situations? Okay. Well, if the parents have negative destructive behaviors, possibly addictions, the child learns that. Okay. Or there's something else called learned helplessness. Basically, meaning no matter what you do, you cannot change your predicament. And they did a study. They put dogs in a cage and they shocked the dog, but they put a lever in the cage that the dog could tap on to get rid of the shock. So they put the shock on, the dog touches the lever, the shock goes away. They do it again, the dog hits the lever, the shock goes away. and then they turn the lever off. So the lever no longer can turn off the shock. The dog gets shocked, hits the lever, but nothing happens. More shocks, hits the lever again, but nothing happens. And this goes on until eventually the dog just sits there, doesn't bother hitting the lever anymore, and just accepts its fate of being shocked. This can happen, and this can happen in an economy also. For example, if the price of houses is going up very quickly, people are trying to save for a house, but they every time they save enough money, they think they have enough money that house went up in value even more. So sometimes people just give up. Well, I would urge you, if you want to buy a home, eventually that economy that's going up very rapidly will come down in a recession, and that is the time to buy your home. And that's when I bought my home in Port Jefferson in 1991. And again, there's probably no one theory that can account for mood disorders. It's probably an interaction of nature and nurture, and that's called the stress diathesis model. It's basically an interaction between your genes and the environment. If you have depressive genes, but your environment is positive, you're not going to get depressed. And it applies to anxiety. If you tend to be anxious, but your environment is calm, you're probably not going to get anxious. But if your environment becomes tremendously stressful, then you could become anxious. Stress diathesis model. And again, let me go back here. Probably most illnesses, physical and mental, cancer, for example, are an interaction of genetics and the environment. For example, if you have oncogenes, meaning you have cancer genes in your family, and you smoke cigarettes, you're probably more prone to getting cancer than someone who smokes cigarettes but doesn't have oncogenes. Okay, that's the interaction. Most physical illnesses work that way. Not all, but most. Psychosocial treatments for depression. Well, again, we spoke about psychodynamic or psychoanalytic. That's Freudian. They lay on the couch. They talk about childhood traumas and losses, how those losses might be similar to an event happening now, and how you're triggered to react to it. Cognitive behavioral therapists, again, they identify cognitive distortions and irrational thoughts and have the patient actually you have to do homework in cognitive therapy and learn over time to counteract those automatic negative thoughts. The behavioral therapist um, helps the patient develop behaviors that are not self-defeating. Um, for example, maybe during the 70s when the disco era was going on when I was younger, everybody was going to discos and dancing, and maybe someone couldn't dance, or they really couldn't go out and socialize because it involved dancing. The behavioral therapist might say, "Well, why don't you take dancing lessons and learn how to dance to help the person socialize?" Okay, so let's talk about the biologic treatment of depression. When I say biologic, I mean predominantly medications. Okay. There are a group of medications called MAOIs, and that stands for monoamine oxidase inhibitors. Whenever we hear an ASC at the end of a word, that means it's an enzyme. Well, monoamine oxidase is a group of enzymes that floats in the synaptic space in between the nerve cells and breaks down the neurotransmitters. So neurotransmitters can be either sucked up into the presynaptic nerve to be released again, or they can be broken down into their components and then absorbed into the presynaptic nerve in components and then reassembled to be released when another electrical impulse comes down that nerve pathway. Okay. Well, they were discovered in about 1952, and in actuality, they were anti-tuberculin drugs. Little sidebar here. The Ammerman campus was actually a tuberculosis hospital back in the 30s. Once we got antibiotics, we didn't need those hospitals anymore. So in 1959, those buildings were converted to a community college. And if you ever go on that campus, you will see some very, very old buildings. One of them is called Tricyclic Hall. All right. So what they noticed when they gave these patients these antibiotics, basically, they noticed that their mood became elevated. They said, wow, they're in a much better mood here. So That was what's called a serendipitous discovery, meaning just out of good luck, we discovered this. In fact, most medications are discovered serendipitously. For example, here, Prozac was developed to be a diet pill. Its weight loss effect went away after about 3 weeks or a month, but the people doing the study on it noticed the people in the study, their mood was better. So Eli Lilly looked at it again and said, let's make this into an antidepressant. Called a serendipitous discovery, good luck discovery. Okay, so these people got in better moods by taking their antituberculin drugs. Some of these medications are called Nardil, Parnate, Iproniazid, Selegiline. Okay, and these medicines take several weeks to work. Most antidepressants and most antipsychotics take several weeks to work. That lag time of several weeks is related to receptor adjustment. Okay, your receptors have to adapt to the new level of neurotransmitters. Okay. Okay. There is a problem with monoamine oxidase inhibitors, and we're going to see that right now. Well, there's what I just described here. Monoamine oxidase inhibitors inhibit the breakdown of catecholamines in the synaptic cleft. MAO normally prevent excessive amounts of catecholamines and tyrosine precursors from being absorbed through the digestive tract. So not only does monoamine oxidase, not only is it in between your nerve cells, but it's in your digestive tract to prevent the absorption of too much tyramine. Tyramine gets converted to dopamine and adrenaline or norepinephrine. And remember, both of those are excitatory neurotransmitters. What do you think excessive amounts of adrenaline and dopamine would do to your blood pressure? It would increase. So these medicines can cause a rapid increase in blood pressure. We'll see that in a slide or two. Okay. If too much catecholamines or tyramine absorbed can cause hypertensive crisis. What's called a hypertensive crisis. Just so you know, in the very bottom here, it's somewhat cut off. If someone's on a monoamine oxidase inhibitor, they have to be off that monoamine oxidase inhibitor for at least 2 weeks before they can start on another antidepressant. Okay, because that could result in a hypertensive crisis or what's called serotonin syndrome. We'll talk about that in a few slides. So monoamine oxidase inhibitors block monoamine oxidase. Now you can't break down adrenaline, dopamine. You get too much of it, and you can have a hypertensive crisis. There are certain foods that are very high in tyramine, and they tend to be aged foods. Liver and liver products, aged meats, pepperoni, sausage, salami, all the good stuff here. Bologna, cured or preserved meats, caviar, cured fish, maybe herring. Also avocados, fava beans, sauerkraut. Sauerkraut is aged cabbage, right? Overripe fruits, canned figs. All wines and beers, but particularly Chianti wine. So as a general rule, this patient should avoid any aged foods. Okay? What would really happen here is the dietitian would come up and speak to these patients and tell them what to avoid. Another group of antidepressants called tricyclic antidepressants, also called TCAs. This is the second type of antidepressants. They were invented in the 60s. They act by reducing the reuptake of adrenaline and serotonin to the presynaptic nerve. You know, if you read different books, some books they say they block adrenaline, serotonin, and dopamine. Some books they say it's just adrenaline, dopamine. Because in reality, it's very, very difficult to measure neurotransmitter levels in between nerve cells. That's a very hard thing to do. We're getting a little better at it with PET scans. Okay? So these are quite good antidepressants, but they're not first line, and we'll see why in just a few minutes. They are called tricyclic antidepressants because they have, in their molecular structure, they have 3 rings. Actually, it's a benzene ring. If you took organic chemistry, it's a ring of molecules. They have 3 of them. Okay? Again, quite effective, but many side effects, and they also take several weeks to work. Let's look at some of these side effects. Well, anticholinergic side effects, remember, can't see, can't pee, can't spit, can't. Okay, as in constipation, a dry mouth, cause a lot of sedation. They cause adrenergic receptor blockade. In other words, they block the adrenaline receptor. That can cause orthostatic hypotension. When you stand up, your blood pressure cannot rise quick enough and you can faint. Okay, orthostatic hypotension. They can cause tachycardia, which is a rapid pulse. And the biggest problem here is they can cause cardiac conduction abnormalities, particularly in overdose. In fact, they are lethal in overdose or can be lethal in overdose because they can make the heart beat very irregularly. They also should be avoided during pregnancy. And as a general rule, all medicines should be avoided, but sometimes we don't have that choice. In fact, I was working with a woman who told me she was going to get pregnant. I was prescribing, and I had to refer her to the high risk pregnancy center at Stony Brook. That is beyond my scope of practice. Pregnancy. So the tricyclics are quite good antidepressants, but they can be lethal in overdose by cardiac conduction abnormalities. Here are some names of common tricyclics: imipramine, amitriptyline, nortriptyline, diazepamine, clomipramine, amoxapine. Notice the ending tends to end in INE. Most drugs in the same category tend to end in the same letters about 80% of the time. And I would tell you, if you can get 80% of your med questions correct, you're in good shape. Another group of medicines that tend to end in the same letters are benzodiazepines. Diazepam, which is Valium, alprazolam, which is Xanax, clonazepam, which is Klonopin. They end in AM. Oh, well, in about 1987, a blockbuster medicine came out called fluoxetine, also known as Prozac. Again, another name could be Sarafem. Okay. They are selective serotonin reuptake inhibitors. In other words, they selectively block the reuptake of just serotonin. On the other hand, the tricyclic antidepressants, they block the reuptake of adrenaline, dopamine, and serotonin. So you had mood elevation, but since you were elevating other neurotransmitters, you had side effects. So they selectively reduce the reuptake of just serotonin, resulting in mood elevation with few side effects. Some of the side effects could be decreased sex drive. That tends to stick around. Transient side effects could be GI upset, possible nausea or diarrhea, but they tend to go away um, over time. They're transient. They tend to go away. The sexual side effects can be dealt with by adding bupropion, Wellbutrin. That'll elevate adrenaline dopamine, so that can help with the side effect of lack of sex drive. Another problem, which is somewhat unique to Prozac, is is considered activating. It can cause people to get agitated sometimes. So I would not prescribe somebody Prozac who had an anxious depression. I would probably go with Zoloft or Lexapro or maybe Pac. There's a bunch of miscellaneous antidepressants. One group is SSNRIs. It stands for selective serotonin norepinephrine reuptake inhibitors. One in this class is called Affective. Okay. Another group, and these are considered tetracyclics, luteamyl, amoxapine. Another one here is trazodone. Trazodone is a pretty good antidepressant. It's somewhat sedating. The biggest problem with it in high doses, it can cause priapism. Okay? Priapism is an erection that will not go away. And most men say, well, that's great. And I say, no, 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 it won't go away. And they say, well, great. And I say, no, 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 it'll have to get surgically corrected and you may never get an erection back. Okay? It's not that common, especially at lower doses, but we would want to educate any man who's taking trazodone about this possible side effect. And if he has an erection that doesn't go away, he needs to see his doctor immediately. The trazodone now is being used for sleep. It is somewhat sedating. Another medicine is called Serotonin, Wellbutrin, we spoke about that, bupropion, and another one called Remeron or mirtazapine. So these are just miscellaneous in their own categories. But probably the first line of treatment of depression is the SSRIs, Zoloft, Prozac, things like that. Well, if you have too much serotonin in the synaptic space, known as the synaptic cleft, you can get what's called serotonin syndrome. And that can happen by mixing two serotonergic drugs, maybe Prozac and an MAOI, or an antidepressant with St. John's wort. St. John's wort is an herb, a plant, has antidepressive properties. It's quite good. But if you mix it with Prozac or another SSRI, you can get serotonin syndrome. We'll talk about the symptoms of that in just a second. Um, it's very important that we ask our patients when they're admitted, what medications are you taking, Mr. So-and-so? Do you take any herbs or supplements? They might not volunteer that to us because they think it's an herb, it's natural, it can't do anything to harm my body. That's not true. In fact, many medicines are derived from plants, such as morphine comes from the poppy plant. Aspirin comes from the willow tree. Okay? So it's very important that we ask our patients, do you take any herbs or supplements in addition to their medication? If they're on St. John's wort, you would tell the doctor immediately, and the doctor would probably put a hold on the antidepressants for maybe a week or two until that St. John's wort is out of their system, and then put them back on the antidepressant. And there's an example, MAOI with an SSRI. The serotonin syndrome is very, very serious. It's a medical emergency. You're going to hold that medicine and call the physician or the prescriber immediately. Signs and symptoms: confusion, agitation, sweatiness, hyperreflexia, hypo or hyperthermia, shivering, tremors, tachycardia, and muscle rigidity. This is very serious. Okay, so again, you want to hold it and call the doctor immediately. Well, let's talk about the treatment of bipolar disorder. But let me start out that lithium was the only mood stabilizer that was available until about 35 or 40 years ago. And I had just started nursing, and it was about 1984, working in a hospital. And I noticed that bipolar patients were being put on anti-seizure medicine. And I'm saying, well, this is kind of weird. Why would they do that? Well, let's think about this logically. Let's go back to the synapse. A seizure is the nerves in the brain are too exciting in the sense they have too much excitatory neurotransmitter. So to counteract too many excitatory neurotransmitters, you want to elevate GABA. Okay? Well, it turns out that most anti-seizure medicines elevate GABA because GABA is an inhibitory neurotransmitter that calms the brain down. In fact, in an acute crisis of someone having a seizure, we give them an injection of Valium, diazepam, benzodiazepine. Okay? Okay, back to lithium. So lithium is the gold standard. It's probably the best mood stabilizer we have, but it has side effects, which we'll see in a little while. Okay. Lithium is a salt, okay, that probably slows impulse control. So the theory here is that if you remember, the axon has a sodium-potassium pump, I believe pumps sodium out or in and potassium out or in. Well, lithium competes for that sodium receptor and jams it up a little bit. So it calms the nerve down. The nerve becomes less reactive. If that nerve is less reactive, it doesn't release its excitatory neurotransmitters as rapidly. Okay, and it can reduce mania that way. What happens with mania? Let me go back a little bit. You have massive releases of adrenaline, dopamine, and serotonin. That's the manic phase. And then, in a sense, although it's probably more complicated than this, you run out of your feel-good neurotransmitters, adrenaline, dopamine, and serotonin, and that's what causes you to go into a depressive phase of the illness. Okay, let's see here. So we'll talk about how lithium works in 1 second, but I want to say that lithium has what's called a narrow therapeutic index. And that means that the toxic range is right next to the therapeutic range. So if the person takes a little bit too much lithium, they can push themselves up into the toxic range and have quite bad side effects. There's another medicine that you may have heard of, if not, you're going to hear about it, called digoxin. That also has a very narrow therapeutic index. You will learn when someone's on digoxin, you must take their heart rate with your stethoscope right over their heart. If it's less than 60, you hold the digoxin. Again, toxic range is right next to the therapeutic range. Dosing is very, very critical. We can measure blood levels of lithium, and there's a range here. The range I have here is 0.5 to 1.5. I believe your book is either 0.8 to 1.2 or somewhere around 1. And I would say we want to pick a number, if there's a multiple choice question here, the number closest to 1. When you go above 1.5, you can get side effects. And lithium also takes several weeks to work. Let's look at some acceptable side effects of lithium. And many will decrease as the patient gets used to the drug. Some mild nausea and maybe some vomiting, some mild diarrhea, some mild hand tremors, some polydipsia, meaning you're drinking a lot, polyuria, you're peeing a lot, some lethargy and fatigue, and sometimes people complain of a metallic taste in the mouth. People usually, either these decrease over time or the people can adapt to them. Well, if you have a lithium level higher than 1.5, what's going to happen? Nausea, vomiting, muscle weakness, slurred speech, hyperreflexia, diarrhea, agitation, twitching, rash, incontinence, polydipsia, polyuria, impaired memory. Not good, not good. Okay? Well, if you go above 3 milliequivalents per liter, you have reduced consciousness, cardiac arrhythmias, seizures, cardiovascular collapse, and you could die from this. So lithium is a little bit tricky to dose, but it's a very, very good mood stabilizer. Well, as I mentioned a few minutes ago, lithium competes for the sodium receptors. Table salt is sodium chloride, and we know that uh, sodium is used in nerve impulse transmission. Well, lithium competes for that receptor, okay, and it bumps the sodium off. By binding to that receptor, it calms the nerve down. So let's talk what happens here. If someone is stabilized on lithium and they start to add lots of salt onto their food now, they effectively lower their lithium. Okay, so they might go into a manic phase. On the other hand, if they sweat excessively, they start to jog, they start to sweat, they're sweating out their sodium, so lithium goes up and they could have lithium toxicity. So what we have to do is whatever level of sodium the patient is taking while they're getting stabilized on lithium, they should continue at that level. If they decide to add more salt to their food, they should probably consult their physician. If they decide they're going to start working out and they're going to sweat a lot, they should probably consult their physician because the physician is going to take lithium levels to see which way this lithium is going to go. Okay? Well, there's also some long-term problems with lithium. Weight gain, also thyroid damage resulting in hypothyroidism, kidney damage resulting in the need for dialysis, in addition to the other side effects we see below. But thyroid and kidney damage can occur in long-term high-dose use of lithium. So we have a great medicine here with a bunch of side effects, and that's what makes lithium a second-line medication for bipolar disorder. First-line medicines are the anti-seizure medicines that we'll see in a second. I'm just making sure it's recording. It is. Let's look at other anti-mania drugs, and they're also known as mood stabilizers. Most act on GABA, thus calming the brain. Again, remember, GABA is the brake of the brain. Adrenaline and dopamine are the gas pedal of the brain. One of these medicines is known as Tegretol. The generic name is carbamazepine. Okay, it can stabilize mood quite well. It's an anti-seizure medicine. A problem here is it can decrease red blood cell and white blood cell production. And it can be used, but you have to monitor the blood count. Another medicine, valproic acid, also known as Depakote. In its liquid form, it's known as Depakine. Can also affect red blood cell and white blood cell production. Very good mood stabilizer. There is a level there. You want to achieve 50 to 100 those units. I don't quite know. I have to look at the lab to interpret those units. Another medicine called gabapentin, also known as Neurontin. They used to think it worked on GABA, but they have since realized it stabilizes the neuronal membrane. Another medicine called Topamax, again anti-seizure. Klonopin, known as clonazepam. It's a benzo that elevates GABA, thus calming the brain down. Okay. Most of above med side effects can be fatigue, ataxia, GI upset, and in rare cases, agranulocytosis, which really is a decreased production of a type of white blood cell. Okay. Well, there is a electroconvulsive therapy. It is still used. Prior to 1960 or so, they were trying anything on mentally ill patients to get them well. Anything. Insulin coma therapy, things like that. Well, one of these treatments from way back is called electroconvulsive therapy, and it's still used today. It is very effective treatment for depression, used to treat non-medication responding depression, also maybe mania or psychosis that's not responding to medicines. Electroconvulsive therapy is used. Most of the time, it's used for what they call intractable depression, depression that is not going away. What happens here is the doctor puts electrodes on the brain. It can be one on each side of the brain or just one on one side. He puts electricity into the brain. That electricity into the brain causes a seizure. Okay, probably related to releasing of neurotransmitters in the brain. Someone with a stopwatch measures that seizure. The person must seize for at least 25 seconds. Probably at about 25 seconds, the doctor turns off the electricity. If the seizure continues after 90 seconds, we're going to give that patient an injection of Valium. Again, that's a benzodiazepine, known as diazepam. Okay. Well, in the old days, in the 40s and 50s, when they gave electroconvulsive therapy, the person would literally, you'd see them seizing on the table, and they'd have nurses' aides holding down the patient's arms and legs because they could break their bones. Someone figured out we can give these people a neuromuscular blocking agent called succinylcholine. Okay, let's go back to anatomy and physiology here. If you remember, acetylcholine is the neurotransmitter at the neuromuscular junction. Well, succinylcholine fits into that acetylcholine receptor, but does not activate the muscle. It's like a dummy neurotransmitter. So you give this person succinylcholine. In the meantime, you put a tourniquet around one of their ankles so that succinylcholine cannot get to the muscles of the foot. When you turn on the electricity, you see the toes of that foot curling, and that we're seeing a seizure. But the rest of the body, we don't see seizing because the rest of the muscles are paralyzed by succinylcholine. So ECT given nowadays has much less side effects than it did 50 or 60 years ago. Sadly, most patients don't know that. Many patients have seen the movie One Flew Over the Cuckoo's Nest, where Jack Nicholson has shock treatment and comes out kind of staggering, and they don't want to have it. So one of the hardest things I've had to do in my career is to convince people to get electroconvulsive therapy. In other words, the doctor prescribes it, the doctor goes in the patient's room, says, I'd like to give this treatment to you, and they say, no way, I am not having that. So One Flew Over the Cuckoo's Nest. Doctor leaves. I go in the room, sit down with the patient calmly, and explain to them how this works. and that One Flew Over the Cuckoo's Nest was made in Hollywood. It's not real life. Okay? And that's where nursing comes. Psychiatric nurses have to explain the procedures to the patient. Well, let's look at some side effects of electroconvulsive therapy. There is some temporary short-term memory loss. Okay, mild transient confusion, some fatigue, maybe a headache. The headache responds very well to Tylenol. I've had patients come back from ECT. They complain of a little headache. You give them some Tylenol, and the headache goes away. There are no well-documented long-term side effects of electroconvulsive therapy. The problem with electroconvulsive therapy is the name is very scary. So I often say we have to come up with a better name for it. Let's talk about the nursing process here. Of course, we want to look for signs and symptoms of depression or mania, okay, as previously described. Let's look at some interventions here. When anybody gets admitted for depression, or for that matter, coming off of stimulants, we want to ask them and assess for suicidal ideation, SI. We observe the patient. Are they giving items away? People that are suicidal are not future oriented, and so they give items away. We want to observe for that. Okay. If a plan of suicide is achievable on the unit, you want to put that person on one-to-one. In other words, get the nurse's aide or another nurse to sit with that patient while you go call the doctor. We would certainly want to move that person to a room close to the nurse's station so we can observe them. We want to maintain a safe environment, searching for sharps, belts, shoelaces, electrical stuff, cords, things like that. In fact, every patient on the psychiatric unit and on the detox unit has all their possessions searched for anything that they could use to harm themselves. And we lock it up, and when they leave, we give it back to them. We could also do a verbal no suicide contract. Ask the patient, Mr. So-and-so, do you agree to come to the front desk if your suicidal thoughts get worse? Now, of course, we can't depend on this, but it's just another tool we have to help the patient not commit suicide. We can assess for psychosis, again, by asking, are they hearing any voices? We can observe. We can ask about a history of substance abuse, ask about a history of depression. We want to encourage socialization. Okay. In fact, if someone gets admitted for depression, especially a young person, the first thing you probably want to look at is, are they doing stimulants? Are they abusing cocaine? Because we know when someone comes off of cocaine, that they're going to have a deficiency of adrenaline, dopamine, and serotonin, a deficiency of excitatory neurotransmitters, which means they're going to be depressed. And when nurses hear depression, the first thing we think of is potential suicide. Okay? So we want to encourage this person that's depressed to socialize. We know that when people talk to other human beings, they feel better. They probably release some serotonin. Humans are the most social animals on the face of the earth. How do I know? Everybody's got a cell phone. Okay? If we were cats, we wouldn't have cell phones. People like to communicate with other human beings. So again, we want to encourage this person to socialize. Again, we're not going to force them to socialize. We're going to encourage them. Mr. So-and-so, why don't we take a walk around the unit today a little bit, and we can talk a little bit, just for 5 minutes. That's all. Maybe the next day, Mr. So-and-so, why don't we walk around the unit for 10 minutes and talk? Things like that. We may have to assist with ADLs because when someone is severely, severely depressed, they can't even take a shower. They might not have the energy to brush their teeth. So we may have to do that. We might want to monitor their weight if needed, if they've lost a lot of weight. And something very important here is there's an increased risk of suicide in early medicine treatment. So what happens here is the person has thought about suicide, but doesn't have the energy to act it out. And then you give them an antidepressant and they perk up. Now they might have the energy to carry out that suicidal ideation. So as nurses, if someone's just started on antidepressant, we want to be very vigilant as to their mood. We might even want to move them to the front of the unit where we can observe them. Again, we can establish small achievable goals for the patient. Maybe today they'll eat 10% of their tray, and a couple days later, maybe 20%. Maybe we'll get out of bed for an hour a day today. Maybe they can bathe themselves. Maybe they can socialize with one person per day, and we'll increase that over a couple of weeks. Maybe they can join groups. But again, we're not going to force them, because if we force them, we make them feel worse because they can't meet the demand put upon them. We want to encourage them. We might want to assist the client in organizing and solving concrete life problems. And it might not be something that we consider a problem, okay, but to them it's a big problem. Let me give you an example. I was working in a hospital and I saw this patient pacing the unit. I walked up to him and said, "John, you okay, John?" He said, "No, no, no. I'm going to prison." I said, "What happened? Why are you going to prison?" "I don't have health insurance. So when I get discharged from the hospital, the police are going to arrest me and bring me to jail." I said, "John, you're not going to go to jail for not having health insurance. In the worst case scenario, you will have to make a good faith effort to pay it back over the rest of your lifetime, something like $25 a week." Probably what would happen is the social worker would get this person on Medicaid, and Medicaid would pay the hospital bill. That's an example of something we would never think of. When someone's depressed, they think of all the worst case scenarios they can think of, all the worst outcomes. Okay, and our job is to educate them that that's not going to happen, or if it could happen, help them work on how they can avoid it. We also want to help the client identify those cognitive distortions we spoke about. Okay, all or nothing thinking, disqualifying the positive, jumping to conclusions, emotional reasoning, should statements. That's very interesting. Depressed people sometimes say, "I should be doing this, I should be doing that, I should be doing that." In fact, in the book Feeling Good, he says, "Don't be a should head." Okay? We want to tell the patients, try to take the pressure off yourself. You don't have to do everything now, because they put a lot of self-imposed pressure. We also want to tell the patients, and this is in the book Feeling Good also, that a feeling is not a fact. You may feel worthless right now, but that's not true. You have worth. It's your illness, depression, that's making you feel worthless. That feeling of worthlessness is a trick from your illness. That will go away when the medications begin to work. We also might want to have the patient think of 3 things they like about themselves and put a list on the mirror so they see it every morning. For example, I have found, working in this for about 20 years of my career, that depressive people tend to be very empathetic and compassionate, very kind and very loving. Those are wonderful human traits most of us value. So we say, put these on your mirror. You have these wonderful traits. Look at them, value them. In fact, I noticed that they have these traits. And I was reading a journal article about a year ago, and there was a medical school in LA, California, and some of the medical students were becoming depressed. And they sent them to the psychiatrist, and the psychiatrist said, "We want to get rid of your depression, but we want to keep your empathy." Empathy is very, very important. And I would say empathy is the most important human emotion. Without empathy, bad things can happen if we don't care for one another. Let's look at some interventions for mania. We assess for homicidal ideation, HI, by asking the person in a manic phase, it's not going to harm themselves, but if they get angry, they could harm somebody else. And we want to ask them, do you have any thoughts of harming anybody? Okay? We want that manic person, allow them to exhaust their energy. If they want to walk around all night long, let them. As long as they're not waking up patients, let them walk. Okay. We want to provide a low stimulus environment. Remember, they're very hyper, so we want to keep the environment very, very calm. And I would say here, choose your battles. If the patient doesn't want to eat sitting down, let them walk and eat. Let them walk all night, like I said. In other words, give them a wide berth of acceptable behavior. as long as they're not bothering other people. Because if you micromanage everything they do, they're going to get angry. Even with your children, you on everything they do, you're going to make that kid anxious and neurotic. On the other hand, we might want to step in when our child is walking toward the road saying you can't go toward the road, it's unsafe. But we don't want to micromanage our kids and make them really nervous. We administer meds when ordered, okay, and usually when patients are in the hospital for bipolar disorder, they're going to have medications prescribed. The problem is, you might remember I said that people tend to like mania. It's very similar to the cocaine high. So what they do is you give them this mood stabilizer, maybe lithium, and they put it in their mouth. And you ask them, did you swallow that pill, Mr. So-and-so? And they go, I did swallow it, yes, and they put it in their cheek, and then when you turn around, they spit it out. So what we have to do is give them the pill, give them the water, watch them swallow it, and then ask them, Mr. So-and-so, can you open your mouth so I can just make sure that you swallow the medicine? And they open their mouth and we look in their cheeks to make sure they swallowed it. And that can also happen with depression. But the depressed person is not spitting out those pills because they don't want to get well. They might be saving those pills when they get enough of them to try to attempt suicide. So we also might want to check for cheating in a depressed patient. We want to educate patient about their meds, the purpose of the meds, the side effects of the meds, the importance of med compliance. Um, uh, Kindling, that if they stop taking their meds, their illness can get worse. You might remember the concept of kindling. And it first was developed in seizure disorders. They noticed once a person had a seizure, without treatment, it was easier to get future seizures, meaning you needed less stimulation to get a seizure. Well, that now applies to mental disorders. Once you have your first panic attack, once you have your first depressive episode, once you have your first psychotic episode, without treatment, it becomes easier to get future episodes. Okay, so med compliance is very, very, very important. In fact, we would probably only need one psychiatric unit in all of Suffolk County if every patient took their meds. But what happens is people feel better and they stop taking their meds. And the illness is a genetic illness, so it doesn't go away. They're good for a few weeks and then they emotionally collapse and they come back into the hospital. Okay. Educate about illness. We want to teach the patient about their illness, what's causing it, what neurotransmitters are involved, signs of relapse. In other words, they're getting worse, signs to look for. The effect of stress on mental disorders. We know stress is the primary stimulus in mental disorders. I think I had said to you guys, I could make any one of you become psychotic, just keep you awake long enough and fire a gun off next to your head randomly where you can't predict it. And some people might become psychotic and anxious in a day. Someone else might be 3 days. Someone else might last a week. Okay. So we want to educate them about the importance of stress. Also, the need for sleep. It's called sleep hygiene, going to bed at the same time every day. It's very important to get a good pattern because sleep is really the time that restores us. Okay. Also, the need for a routine. All humans like predictability. We like a routine. And the big problem with COVID right now, in addition to possibly getting sick, is a disruption of our normal routine. Right now, I'm struggling a little bit with this computer. I'm not in my routine, although I'm adapting to it. But when we break routines, people get anxious and their mental disorder tends to get worse. Let's talk about this is still going. Let's talk about suicide. I want to say that we don't say someone committed suicide now. We say someone died by suicide. We don't say someone um, died by schizophrenia, right? So we say they died by suicide, not committed suicide. Okay. Usually related to depression, suicide, but not always. It's the 11th cause of death in the USA and rising. And I think it's probably rising because we tend to become more isolated from each other over time. 100 years ago in the same house was the grandparents and maybe the aunts and the uncles, but nowadays people can live alone, and when you live alone, you don't have the socialization that you might need. We also know that more women attempt suicide, but more men succeed. And that's because men attempt suicide in violent ways, such as guns, things like that, where women may overdose on pills. If we can get them to the hospital quickly, we can pump their stomach and get the pills out of them. Men, because of testosterone, tend to attempt suicide in violent ways. Suicide is lowest among Afro-American women. I don't know why. There's a strong association between the serotonin deficiency and suicide. Suicide is contagious in a family and an environment. So if a patient commits suicide while on the unit, we have to be very vigilant that other patients aren't going to mimic that behavior. Okay, we're very aware of other patients saying, oh, well, that patient did it. Why can't I? Also, if it happens in a family, children, if they learn about that, they can say, oh, well, daddy did that. So therefore, if I get in a bad state of mind, I can do that. In fact, I will have you look up Donald Mannis. Okay, you can look him up. He was a New York City politician who committed suicide. I should say died by suicide. Okay. Increased risk of suicide. Ages 15 to 24. That's really complicated time in people's lives. Trying to establish your career. Who am I? Gay, straight, good, bad, black, white. Trying to fit in society, trying to see where you're going in life. Okay. Also, people that are older than 65 years old have an increased risk of suicide. Pre-existing mental illnesses increase the risk for suicide. Uncharacteristic rapid improvement. For example, this person is been very depressed for a long time, and all of a sudden one day you come to work and the person's in a great mood. That doesn't happen. Depression doesn't go away in one day. Okay, so you have to say, well, what's going on here? And it may very well be that that person is planning to leave this earth. So if you see someone's mood get well very, very quickly, that's a red flag. We have to observe this person very, very closely. Highest risk for suicide is retired, elderly, single white men with chronic health problems. Let's dissect that a little bit. Well, persons who is retired may have a decreased sense of purpose in life. They've also are not seeing their colleagues at work, which can become friends, right? Single, you don't have a wife to talk to. Also, men tend to be not as social as women. Okay, women tend to have talk to other women a lot more than men do, so they have less social support. And then you throw in chronic health problems, where the person is quite sick and the risk continues to go up. Well, there's a gentleman named Kevin Hines. He tried to die by suicide, let me correct myself, by jumping off the Golden Gate Bridge. And from what I have read, he was actually saved by a sea lion. You can go online and type in Kevin Hines and read about his story. Let me just make sure we are recording. Yes, we are. Conclusion. Mood disorders are one of the most common mental disorders. Fortunately, they are very treatable. Our job is to assess, relay information to the team, offer patient hope that through work and getting treatment, they will get better. We want to help also decrease the stigma of mental disorders because stigma prevents people from getting help. Our job is to keep the patient safe and administer medication. So in short, depression can be devastating, but in reality, it's very, very treatable. Bipolar disorder, although can have depression part of it, bipolar can be a little more difficult to treat. Alrighty then. I finished this lecture. I'm going to post it on YouTube in just a few minutes, and then I will record the other lecture, which will be schizophrenia. You guys have a good day and keep on studying. Hold on. How do I get this thing to turn off here? There we go.